think the next question to parent satisfaction when we apply transdisciplinary method and how is it different from other approaches? Has the patient satisfaction, according to you, has risen with transdisciplinary method? If you feel yes, can you give illustrations from five foundations?
So as we already discussed about, how it can be overwhelming for families, and the families are really desperate, and the amount of information they have is either very basic, or sometimes they come with no idea of what to look for. That they've gone to a doctor, they've gone to school, and they've just said go to a speech therapist or go to a particular center. Or sometimes you have families who have been for all different kinds of therapies, they've tried everything under the sun, and then they come to you. So you have a whole range of families who do come and approach us, right? And as it is with us, when we go for for either whether it's a hospital or a job or anything new takes a while for us to adjust to, right? And for families who have no idea of what therapy is like, it's like they say, it's easier to, when it's a blank slate, then it's easier for us to work with. And there again, what happens, I think, in both cases, either if it's a family who has no idea what they're coming in for, or a family who has, very specific, they come to you very clearly saying, this is what I want, this is the approach I want, this is what, I am looking for. Either ways, I think, when you first straight away let the family know that they are an equal part of the team, that it's not that either they dictate terms to you or we dictate terms to them, that you become an equal part of the team, there itself you set a very good foundation. And the trust builds in. So I always, one of the policies that we have at Five is we spend a lot of families before actually starting intervention, because you want to set the expectations, you want to have very realistic idea of what you're getting into, because it is unfortunately most of our families have to pay for their own services. It's not, many are not insured, or they don't have funding for it, so it comes out of their hard earned money, and time is money for them, and every different. So it's not something where, okay, let me try speech therapy here for 3 months and let me go try something else there 3 months, right? So you want to make sure that you value that family's time, effort, emotional state, the financial, all of it. So you need to respect all of that. And when you let the family know that we are in this together and your starting is at the same level, there itself you sort of set your expectations well, both ways. Like I said, either you have families who have no idea and say, here's my child, do whatever you have to do, or you have families who have very high expectations of the therapist. So in either case, spending time with the families in the beginning, saying, okay, what are you looking for, what do you know right now, what is your understanding of what's happening, where do you come from, what have you tried before, what's worked, what's not worked, and okay, this is what I have to offer. Because there are times when a family comes to us, we have all these initial discussions, and we realize that we are possibly not the most suitable, because for some families they have very clear expectations that if I've come to you for speech and language therapy, I don't care if my child is hyperactive and needs sensory integration therapy. I want speech therapy, you give me speech therapy. Now then it's up to the therapist to decide, to help the family understand it. But somewhere, if you feel your dynamics is not working out, then it's better to let the family know that I'm not the best person to work with you. There might be somebody else who better suits your requirement. Because as a professional, I have an ethic, I have a responsibility to let the family know that this is how I see it. Not telling them that, okay, I've done assessment, these are the 5 areas that your child has challenges in, this is how we're going to approach it, let's start working. And that's another thing that I've often noticed, that when we're doing the assessments, if the family is an integral part of the assessment, instead of me telling them that this and this is what I see wrong, if I tell them, okay, we did this activity together with the intention of assessment, what did you see? Is there something that's different from what you see at home? Did the child behave differently? Did the child do something different? So if the assessment is done with the inputs of the family, with the family, and very often you'll have family that say, oh, I didn't realize this, or oh, I didn't see that. And when you do that together itself, which is again an integral part of TT, transdisciplinary approach, where the family gives you more information, the family gives you more perspective, the family gives you more idea of where it is. Then when you put your assessment report together, they're already with you, they already know what you're going to say, right? It's just that we've all put it down, you've added a few clinical terms, but then you've helped the family understand, not just that, no, I can't, can't do spelling, can't do, why. That's where clinically we come in. We come in with the knowledge and skills that we have, saying, why is it that the child can't do this? Or why is it that he can do something really well, but like he can say all the words, but he's not communicating. So the why is where we come in, and that why, if it is answered by a team, and one answer is given to the therapist, to the family, one explanation is given to the family, it's easier for them to understand. So I think that when you work on that, when you spend a lot of time in that initial phase with the family, then yes, the satisfaction is definitely, because the family already is prepared and understands why when I came to you for a particular reason. Like, maybe I came for, the school told me that he's bad at spellings, and then I've come to you, I want a special educator to work on spellings. But then the child has phonological processing issues, and if that particular special educator doesn't feel ready to work on that, then you have a speech and language therapist working on it. Or again, the child has handwriting issues, and then they want a special educator to work, but you realize that the OT is the one, or the PT is the one who needs to work with the child, on your gross, or your muscles, strengthening of muscles. Then the family needs to understand that why. So that is, I think, really, really key. And when that happens, satisfaction is there. When you don't spend that time, with the family, making them a part of it, having those discussions with them, that is when you will find them doing like your doctor shopping. They will go therapist shopping. They will try you. You don't suit them, then they will try. So you won't even realize why the family didn't turn up the next day. So that is something that is really, really important for us to, and again, like Srinitya said in the beginning, documentation, putting in one document together. So when we write reports, if my report and the OT report and each of the reports say different things, I mean, imagine the family state of mind, right? So then the therapists need to interact, the professionals need to interact among one another and say, okay, when I was working with this child, I saw this. What do you think? Or you've seen the child once and you're not very sure, then you say, can we do a joint assessment together? And while there are practical challenges that I think we can discuss a bit later, and like it's a very large topic to talk about, nothing is not doable, nothing is impossible, right? It's that you can always find a solution. And that's again the beauty of transdisciplinary, because it's very problem solving oriented. You're always trying to find a way to solve a problem. And with terms of parent satisfaction, anything new is difficult. It is anything out of norm, anything that's, all the other parents I know go to a therapist and the therapist does this, but when I come to you, you're saying something else. It is difficult for the family to understand. But then when you work on with them together, then I think you can, not guarantee, you can definitely have, it's better satisfaction for you. You're being realistic. You're setting the goals, straight off.
So thank you, Soumya. So we can have significant predictable functional outcomes when the family is involved, right? And as the family sees the progress along the way and they have the chance to practice while the professional is around, the opportunities that are available for the child is they are naturally enhanced with this approach, and they feel much more comfortable and they feel like coming to you, and we do justice. So thank you so much for providing superb examples from your experience. I appreciate that. I would like to present the next question to Ms. Malika Ganapati and Ms. Soumya again. Have you both worked in a TD model? And what is the model adopted in the places where you practice? Does it happen in silo or collaboration? Can you give illustrations of any such scenarios? Can you please highlight on the key worker or the primary service provider? Very little, we talked a lot about it earlier. Delivering such approaches in the places you have practiced. Some few examples. Yes, ma'am.
Yeah.
Yes,
Yeah, I can give you three scenarios, three different situations where this has been practiced. One, I think all over in India from mid-80s, I think in CPR programs, transdisciplinary is practiced. But none of us are really aware that it's transdisciplinary. There we practice it because lack of resources. You can't find too many people. We have worked in Tirunelveli districts where one pedipathic worker works with around 10 villages and attached to one organization, and she or he is part of the village, one person from the village who has to be trained. And we have no choice. We don't have speech therapists and physiotherapists and special educators there. So what happens, how we started the training, I remember in mid-80s, is they would come, we would go for the visit to see what these villages are and look at the need, the target population who needs services, get an idea of what the whole thing is about, and then we bring the service provider who is a part of the community to the center in Chennai, and she or he undergoes a 3-week training initially. It's an ongoing training. Every term, 3 weeks they come for training. So little bit of basic skills in all areas we give, but it's very pertinent to the children we saw there. And then they go back and start practicing, and we go as a team, assess the children, give her or him a program so that she can carry out the program, and go for another visit next month to see how the program is implemented. It's ongoing support by a team of professionals, but it is provided, the service provider is one person from the community. Generally, they're not even very educated. Maybe they've done some schooling and they know a little bit of reading and writing. We take people who know reading and writing and who are a little skilled and have the time to move around and speak, interpersonal skills are there. So that's a CBR experience, but the training is constantly ongoing. Every year they come twice or thrice for the training, and we go once a month to see what they're doing and allow them to carry on the program. That is one thing which I'm sure this model is practiced by many people in India. It was done quite early. And I remember in a home management program in early 90s, we started off this transdisciplinary, in-house transdisciplinary training. It's an interdisciplinary team of all 6-7 professionals together, reaching out to 50 children who are either in a mainstream school or very young to attend a special school. So there we started this. We decided that we can't look at the child as just his leg and just his physical movement or speech. We have to look at him holistically. So we decided, let's do the assessment together. So whatever Nitya was talking about arena assessment, we didn't have the term then, but we did it together. We always sit together in a circular team, parent and the child, and one professional the lead professional will interact with the parent and child. But we would have had a meeting before to decide what are the areas we're going to assess. Each professional will give the areas he needs to be assessed, and we will make a comprehensive program which can be done with the child there, so that constantly we are doing, and other professionals are observing. The social worker observes the parents, how she is she relaxed, is she tense, how is the child, is he confident enough to participate, she is assessing the child. The PT and OT are assessing physical aspects of the child. What's the fine motor skills, how is he sitting, what is his attention, does he have any other obsessions? So they are noticing that. And the special educator, of course, what is literacy and numeracy? And the speech therapist is saying, how is he communicating? How is the child communicating? Between parent and child, is the communication good? So we do our own assessment through observation, but one lead therapist does the assessment. And every week, one day, one afternoon, we decided we will have an in-house training program where the speech therapist does training for all the others. Next week, the physiotherapist. So we take turns, to share our knowledge and skills with all the others, and we give them book. We have sessions where we read books together, tutorials, discuss about it. So not only assessment is done together, but we work together to train ourselves, share knowledge, share skills and aptitude. I think that was a very, very important. We have to respect each other, understand different perspectives. For the same thing, 3 people may say different things. Oh, okay. So there are 3 ways in which it could be done. So maybe the parent could choose which is easier for her. So we have to understand the different people, the values, the perspectives, and also empathy, right? And it really, really helped us. And we had to let go, make the parent a teacher. And it's been so effective. I'm going back to the CBR program. One of the CBR trainees who has been trained, called Ishwari, after 20 years, she had 2 sons, adult sons with cerebral palsy. Now they know more. But she started a school in Kumbakonam. She lost her husband. She has no property, absolutely nothing. She lives in that one room, which is a school. And she's running that school with 25 children with cerebral palsy. Now she has started, she's getting government support. She's got a big trust there, trustees, for her supporting. She goes to college and get volunteers to come and work with her. All these college students come and work with her. And now she's working on inclusion. And Ishwari was empowered just by, being part of the CBR program. And we've got parents similarly who now tell us, oh, I think I can meet you once a month now. It's not necessary to meet you very often, but once a month, and I can call you whenever I have a doubt. And they, in turn, have become support for their community. We find another parent in the community. We say, we just go see and talk to her, so that it will open out a new, perspective to them. They talk to her and then they come back and say, yeah, I did speak to her and I saw how she's working with that child. I want to do the same thing. Can you help me? I will see that I follow one organization, one institute, and don't go shopping. They realize the importance of working under one key person and one organization, a team of professionals, but working under one organization and not shopping. Okay, so I think, and inclusion, I would like to add, see, one is CBR, one is interdisciplinary approach, and inclusion. Many schools we find are not including because they can't employ all therapists. They say it's too expensive. We can't afford that resource. And the government bringing in so many restrictions and fees collection and all that, even private schools say we don't have the space or the resource to do it. And what we do is we employ one person there. It could be a therapist, it could be a speech therapist, special educator. Sometimes we even have OT, or we have regular teachers who take charge of the resource room. So we train them. A team of professionals train them to take charge of the needs of the child, and sometimes even the physical educator is taken, is educated on how to meet the therapy needs of the child. And the therapist, whichever therapist is needed, visits and has a meeting with her so that she can take on from there. So I find that it has been really, really effective, and many schools have opted to go in for inclusive education with this model. We have done it even with teachers, existing teachers from the schools. Yeah, it is possible in all environments.
Thank you, ma'am. Thank you so much for bringing in your experience and very inspiring examples, though. Soumya, you just want to add on to that?
Yeah, it's actually one of the reasons why I like the CBR model, because they already understand the need for transdisciplinary. You understand that you don't have access to the number of the supply and demand is so different and so difficult, and the gap is so wide that CBR programs are so beautifully designed already that you recognize that that's a need. You don't have access to professionals all the time. You don't have access to resources. So how do we work around it? But then coming from a private practice background, I think that's the shift in scenario is quite a bit, because unfortunately, as much as it saddens me to say it, somewhere the element of competition and wanting to one up the other, I mean, it is true, it's reality. I think I should just call a spade, and that's how it is, which is very unfortunate, because we are in a profession which you cannot work in isolation. We are in a profession where the only way forward is collaboration. And again, I think all of us have said it over and over again, the family and the child has to come first, right? My goal is not to have a family come to me for the rest of the life. The success of my work is if a family is empowered enough where the child is able to move. And like ma'am said, right, maybe once in a while they still need a consult. They still need to, every time there's a transition, the child's moving to high school or changing locations or, starting work. So then there will be a few transitional issues where the family needs your support again. But yes, it is challenging in a private sector. But again, as I said before, it's not doable. It's not impossible. It's actually very, very, it actually, I felt a lot more empowered. I felt like I was not alone when I was able to connect to other therapists working with the child, working with the family, and say, oh, did you also have the same issue? Okay, I had the same issue. Did you also face the same challenge? So what can we do together, right? So even if it's a scenario where you are working as an independent practitioner, picking up the phone, having constant, like what we would do is have shared Google documents. So you can, you can edit over there, you can add your notes over there. If a child's, going into school, very often we, ma'am talked about inclusion. It is challenging for schools to take, children with special needs in, because there's a lot of support and resources that's required, which is not something that all schools are equipped with, right? But then if you're able to connect with the teacher somehow and say, okay, now, for example, if you say a child's nonverbal and you want the child to be able to use an alternate AAC device and augmentative communication. So I have a visual, a pictorial device, communication device for the child. No, that's not enough if when I'm working with a child for an hour a day, if the child uses that and then the child's lost. The idea is communication. Exactly. The idea of introducing that nonverbal communication of, a picture board or an AAC device is you give the child an opportunity to communicate, even though he's not ready to, use speech as his primary mode. He has a lot to say there. So there is a lot for the child to communicate. And communication is something that happens for every waking hour. So to be able to reach out to the school and say, okay, is there one thing that we can do to make it possible for the child to use this device? So again, looking at what is practically possible in a mainstream scenario, because if you just send that device into school and then expect the teacher to know what to do, it's not going to. So what will happen, that device will just stay, or that a board will just stay in the bag, and then again your child's lost. The child doesn't have an opportunity to participate, right? And similarly, okay, even when we are designing the communication device, or we are deciding on the communication device, you need inputs from the physical therapist, you need inputs from the occupational therapist in terms of how ready the child is, and what would be the most appropriate communication device for this child, right? In terms of sensory, in terms of posture, and motor control. So you have to have inputs from all these therapists, and for you to be able to include the family, to be able to include the school, to be able to include, like I said, in some scenarios we have had families who find it overwhelming, mothers who have emotional breakdowns. So then you have this mom who's already going through a difficult time, and then you keep bombarding her with saying, you need to do so many things, you need to try and do this. It doesn't work. So again, connecting with her psychologist, or her with her psychiatrist, and say, what is the best way for me to get through with this parent? So I think that's really important for us to find a way that makes sense for the family. I think that's the ultimate goal. So whether you're a single service provider, so just because we're saying transdisciplinary, everybody needs to be together, it doesn't mean that your center has to have everybody. You just have to have the mentality to say that I need other professionals, I need other therapists, inputs from other therapists, I need to share knowledge and skills, I need to understand from other professionals on how to service this family. So you can still be a single service provider, but work in a transdisciplinary approach, as long as you open your mind and say, what is the best way for me to work in collaboration with other therapists for me to better serve this family?
Thank you so much, Soumya. Empowering the families is the main agenda in transdisciplinary approach, and that's going to take us really way far away. So let's go to the next one. I guess we are running out of time as well. So let's go to the next question. Yeah, this is to Dr. Selva Ganapathy. How does the transdisciplinary approach impact the new professional roles on a team member, as there is a lot of emphasis on cross-disciplinary training? So over to you.
Yeah. So the role change happening in a way like for a cause, right? Like if you are if you are decided to share the knowledge, or you are in a position to offer some other skills which you are not from the principal domain, and you learn inculcate some knowledge from the other professions. So at any point of time, I would say that at that particular context or particular scenario, you are in a position to offer, rather than no you just transform to become another profession. So really it won't really impact in your profession, like you are changed into something else. You are always, your skill set is on that particular domain where you belong to, but you are inculcating some more knowledge, right? And that particular scenario, it works. I mean, this is a call has been taken after the team meeting, and the particular problem oriented. So that's why really I don't feel that your role is or your professional role is really impacted so much, right? But if you are working for the common goal, and you are in a situation, that's where this terminology we use, transdisciplinary approach, right? So but I don't see that, I don't really say that no, I have become like occupational therapist now, no, just because I have learned some knowledge. And same way, like one for an example, one ADHD kid come to me, and then I assessed, and then I found that there is a hardly I can do anything about it, right? So but the referral is for me, like the child is falling or something like that. But it's not like really there is a problem of impairments, right? It is again belonging to some other domain, like behavioral component, right? So that sense, like I can very well, so it's, I have to be taking a call like, okay, it's just because I've got the referral doesn't mean that I have to do something, right? Rather than that, I can refer, I can openly agree to it. Okay, someone else would be much helpful. Though the problem looking like falling, which is the domain of physiotherapist, everyone says that falls prevention, everything, no, they can do it. But the real problem is something else, right? So then in that sense, like I'm not enabling, okay, ADHD means always should be treated by no occupational therapist or someone, right? So there are the other child which comes with really having TA tightness, which is causing the fall, right? There are muscular skeletal issue which is there and which is contributing for the fall. So in that sense, like I should know where is that boundary. So I don't really think that we change into some other category. Even like I told, no, in the other project we are empowering someone else. Like definitely they are taking the support from physiotherapist, but they're not actually delivering therapy. They're not a therapist over there actually. They are taking the support from the therapist to deliver, but they're not actually delivering therapy. So if that understanding is there, then we won't say that I have become no physiotherapist or something like that. No, but the thing is, like again, that's where the problem comes. Like the insecurity part comes. If someone is misusing that, then this whole no model will failure, right? So that's why one should not think that now I have changed into something else. You are still physiotherapist, you are still occupational therapist, you're still speech therapist, right? But for the common goal, we are sharing knowledge, and sometimes we are empowering one profession. You are the for one case, I am the lead, and another case maybe occupational therapist or speech therapist. So that's what we should understand. So really, that role suddenly it's changing, it's impacting my entire professional role. I don't see in that way. Rather than that, we are looking for some common goal and we are achieving success, right? So I think I didn't get the second part of it, second part of your question.
Yeah, it's there's a lot of emphasis on cross-disciplinary training. Yeah, that is
That's what.
the
So I
yeah.
think that's what, the training can be given, but doesn't mean that you will be transformed into.
And what is the impact of the new professional roles on the team?
Yeah, that's what. So, like, I mean, you are become a facilitator at one point of time, and definitely at any point of time you cannot no transform into another professionals.
Correct. Yes.
And if somebody is feeling that it's a threat, no, it can happen. So this is the insecurity part. So that if that's clear communication is there, and then together we sit and do the assessment, and then the on rotation, if someone takes a lead role, so that would be helping. I think I'll just recollect one instant when I went to UK. I just observed the NHS setup in the rehabilitation ward rounds I attended, and that particular session was headed by the staff nurse, and the physiotherapist, social worker, psychologist, everybody is there. Even the consultant is not even presented. They are saying consultant will come once in a while. He has to look after too many NHS hospital. He won't be there all the time. We only run the show, and in the weekly basis we'll rotate. And next week, PT will become the head of this rounds. He will be asking the question to speech therapist or OT, what is your plan when you want to discharge, all these things. Like, so it means like you are empowering every team member to lead. So that way this no, the insecurity part also will be taken care. So definitely that your role suddenly it is not totally you transform into something else. Your role is uh, just your treatment provider, but we are using this approach for the benefit of the patient. So that line of understanding is there, then I think it works.
Yeah, thank you, doctor.
Yeah.